a start now. Welcome to our public board meeting. Lovely venue that we have here. We continue to tour around the island to try and encourage more of the public to attend in person, but we've got our old favourites attending in person. And just tell some of your friends to come along, will you? And I know people are watching this as a recording, but I would encourage, there is space for the public, and we will continue to move around the island and find venues in the parts that we've not been to yet. So we have two apologies. Katie Kapanaris, one of the non-executive directors, can't be with us today, and Dr. Andol can't be with us today, but Dr. Marina Hudson is going to be deputising for Sri if we've got any medical issues. And I've got a note that Dr. Ellis is running slightly late, but he will be with us soon. Okay, so that's the welcome and apologies. In terms of declaration of interest, you've got the usual note in the pack. Does anybody wish to add anything to that? Or ask anything about it? No? Okay, so we can take that. Then we've got the minutes of the meeting on the 22nd of January. So I'd like to approve these, but does anybody have any issues they want to raise about them? No? Okay, so...
I just have one question.
Yep.
Were you not with us when we went to Murray House?
I was there for part of it, not all of it, but yes.
It just says SB and KK had met with colleagues at Murray House.
Yep, well, to be accurate, I was there for part of that as well, so true. Thank you. Right, then we've got the Matters Arising Action Log. There's only one action on it, which is shown as completed, which was two directors forwarding their interest to Elaine, and they are now on the register. So that's done. So can I ask anybody that wants to raise anything under any other business later on? Is there anything? No? Right, we're zooming through the agenda this morning. Right, now we will come into some meaty stuff. So, various issues to do with governance development, so I'm going to hand over to Paul and Andy to do this.
Thank you, Chairman. So the first paper I've got before you is an update on the clinical governance roadmap. Can I mind if pointing out the slight error with the way this has been billed on the agenda? It's billed as the CQC Regulation Compliance Update Report. It cannot possibly be that. I don't know why that would have been phrased in that way. But it's the 10-point roadmap for quality governance improvement. I think on the whole, I'll take the paper as read, but we're making pretty good progress on it. In particular, the efforts to consolidate the governance team into a governance support unit is progressing quite well. We're getting a high level of engagement in the consultation, a lot of support from our union colleagues as well, a lot of interest in shaping that team from the members of the team itself, which I think is really encouraging. We're also making good progress on the risk management element. The transformation team in particular, if I can just single them out for praise, they've been incredibly supportive in helping us source risk management practitioner to assist us, and they've given us the go-ahead to go out, which we're actively doing at the moment. And we have some discussion documents on our agenda today which help to move the, that particular work stream forward. We're making extremely good progress on the quality dashboard, which has been seen by the Quality, Safety and Executive Committee, and is giving us some important insights into the quality care provided by Manx Care, some of which I think is really exemplary and worthy of note. But giving us that visibility has helped us enormously. That just needs embedding now, Chairman, and starting to become the core business for Manx Care. Similarly, I think we're making good progress on the operational governance group. We've got a very clear 12-month programme of work which will actively seek assurances on the issues which are relevant to the CQC inspection, and they do link to the CQC regulations. That's been going probably since October, I would say. That's been steady and solid and sticking to its plan. And I know that the Quality and Safety Executive Experience Committee benefit enormously from the assurances that we're able to furnish them with as a consequence of that. The areas where I want to just pause for a moment and just explain, the areas that are flagged as risky, if you like, are the areas relating to workforce, and I think it's known to the board that it's a very big agenda, and we've got some important aspects of the workforce agenda to deal with, not least radically transforming mandatory training and the ability to gain assurance from that, which is flagged in here, but also stabilising the workforce, getting workforce profiles in place, dealing with things like appraisal and professional development are areas which they're quite big, and we've purposefully given them a short period of time because we have to get into a place that puts us in the best possible position for the well-led element of the CQC inspection. So we are trying to accelerate that, which is why we're flagging risk. I have to just for a moment thank my colleagues in HR who have stepped forward and agreed to take the lead on transforming the mandatory training systems for us, working with e-learning Vannin and the PIP system to try and help us to build that assurance base and give managers, frontline operational managers, the insight they need to know where to focus their efforts. So I know Anne and her colleagues are working very closely with us on that. And in all other respects, Chairman, I think the governance development roadmap is progressing quite well. Given where we are, given the challenges we have with COVID, we have kept this programme going because it's important to us. And if it's okay with you, I'll pause and take questions.
Certainly, yeah. And I just want to comment first of all, and I'll pass it on to Andy once the last question, that to me this is one of the most reassuring documents that we are getting, because one of the big challenges we've got is to introduce quality governance and clinical governance across Manx care, and this rigorous, methodical breakdown of this into, I think it's about 64 component parts, and then rating each of them in terms of their progress every time, gives me, as chair, a lot of assurance that these tasks are being done and are being done properly. But just to show that I've read it thoroughly, out of the 64, there are only 2 that are rated red, and they relate to the training needs analysis. Could you just explain a little bit what lies behind that?
Well, it links to the comment I made a few moments ago. So the training needs analysis is linked to the information that's contained in PIP and the information that's contained in e-learning Vannin. Right. And it's about being able to join them together so that frontline operational teams can access a system that tells them what their colleagues are required to do as a mandatory component of their training, but also what their colleagues must also do as a requirement of their role-specific elements. And that will vary. I was having a conversation last night. If you just put doctors down, for example, if you're a doctor working in psychiatry, your role-specific training will be different from an obstetrician, for example. And it's about being able to isolate that and then extract it from the system so colleagues know what they have to do, and then be assured when they've done it. And it's about joining all those various systems together, which is complex, I think, and
I see.
Needs a bit of work on it.
Okay, thanks for explaining. Andy?
Just firstly, echo exactly what you said. This is hugely reassuring. It's really well set out, divided. The commentaries are excellent. I just wanted to make one very, very tiny picky point, and that is the use of the word trust throughout this and other documents, which we are most assuredly not a trust. We're not a UK trust, and I think we just need to be just a bit careful about. It's a tiny thing, but it is a small thorn. I'm really sorry, but the rest of it, absolutely brilliant. Thank you very much.
No, I take on board that point. Thank you for raising that with us.
Okay, so did you want to say something, Teresa?
It's just a comment really, and I'd like to thank Paul and the team for all of the work on this. I think one of the things that we must ensure sort of follows through on this is the sort of data we need and the frequency of that data and the reporting is fed through into the shared service agreements. So we can then expect this to be provided to us on a regular basis by OHR, by eLearn Vannin, by LEAD. So we sort of capture that and make sure it's mainstreamed and embedded. So I think that's, once we're clear about what we need, how frequently we need it, making sure that's reflected in the shared service agreements, which I'm sure Oliver will pick up with the commissioning and contracting teams.
Okay, so I think we're asked to receive the update on clinical governance. We're asked to approve the risk management policy.
Oh, can I just talk about that for a moment? I have to
Sure.
mention Thank you, Chairman. So I'm introducing the board to the risk management policy, and I hope this is the beginning of what will be a really interesting piece of work for the whole of Manx Care. The policy is based on the British Standard Code of Practice for Risk Management, which is widely used. And actually the fundamental concepts in there are also widely used in other risk management frameworks throughout the world. So it's a very consistent approach to dealing with risk. And I think it's going to be helpful for us because it will force us to look at some important elements of how we operate and get into a rhythm. And in particular, knowing what it is we're seeking to achieve, working out the risks that could stop us from being successful in that endeavour, and then most importantly, how we respond to those risks. So we don't want to be paralysed by the problem. We want to be able to find a way through. And I've helpfully illustrated there in a diagram that there are only really 5 ways to tackle a risk. And so what we will do with this policy is we'll demystify risk management, make it really simple, but shift the emphasis away from reactive, costly management of problems to one that's much more proactive and anticipatory. And in doing that, I think we'll find more opportunity to address some of the intractable problems that we experience, but also position ourselves to be fit for the future. So I recommend this policy for approval today. I think this is a really important part of our risk management journey. And you know, once we agree this, we'll take it forward in a series of masterclasses to help socialise it with colleagues who probably understand risk management but might not be used to some of these concepts in the way that I'm using them here. So I'll recommend the policy for approval today.
Okay. Andy.
There's an awful lot of good things in the policy, but I don't actually think it's ready for approval because I think there's an awful lot in here which is basically it describes the UK. It doesn't adequately describe the Isle of Man and Manx Care. You know, without going into detail, it's the introduction itself would lose some of the people who are Manx that work for Manx Care, I think, and things like market share, for instance, isn't actually that relevant, just as an example. And things like the diagram, much as I had to read through this quite a bit to actually get back to the diagram and keep going backwards and forwards because some of the signposting is missing. I think it's just, I think it needs a bit more clarity. What's in it is absolutely brilliant and it fits perfectly with the journey we're on. But I personally don't think this is quite ready for approval yet.
Can you just give us that example, the reference to market share? Where's that?
So it's right in the protect everything of value to Manx Care, and it includes market share, for instance.
Ah, right.
So, you know, and then, I don't want to, I mean, I did read through it extremely carefully.
So it refers to a point that says the key point is to protect everything of value to Manx Care.
Yeah,
that's the important point.
It is absolutely.
But it then goes on to give an example, such as reputation, which is essential for us. I'm sure you'd agree.
I would.
It does say market share, but it could be that we might have in the future designs on expansion, question mark. It also talks about exemplary clinical outcomes, which are, in my view, valid.
Absolutely right. I couldn't agree with you.
So I don't know if I agree with you that this wouldn't be relevant.
What I say is that it's just my opinion. I mean, if I read through it, I see lots of references basically to UK, and it's not actually strictly about Manx Care and the Isle of Man, and I just think that's a deficiency which I think we should probably cure. There is an awful lot of really good things in here, but you know, I can't fault 90% and 95% of the content, honestly.
No, and I take that on board, but I do feel I need to come back on you a little bit. So your point about the UK, I don't think I accept. It's based on international standards for risk management, as I've mentioned. Those are the standards that operate across the world. Mm-hmm. What I would suggest is perhaps someone can explain to me what it is about Manx Care that's so uniquely different that we would need to deviate from that.
Okay, Teresa?
Yes, just I guess in support of Paul, really. I find this incredibly assuring. It's a very comprehensive policy framework, and I believe it is the first time there has been a comprehensive risk management policy across the organisation. in accepting Andy's points around this is a very comprehensive document and might not land. I think that is the sole purpose of doing the masterclasses and having some of those easy read versions, so the full context of how to apply this policy, say in social care, in primary care, in the hospital setting, can now be flowed down from this overarching policy. And I think that's the whole point. Paul suggested that all of the exec become experts in risk management and undertake these roadshows to ensure it's so properly disseminated across all staff. And I do think that's the way of getting the contextual framework correct in the various settings. Risk management in mental health looks very different to risk management in social care, to primary care. And I do think this sort of overarching, quite comprehensive framework gives us a starting point for that to flow down. So I'm quite comfortable with this, and we have had good scrutiny of this executive team.
Sally, and then Nigel.
Okay, just to say thanks, because this was shared with some of our colleagues within social care, and I know there's been some feedback that has probably not found its way into this yet because of timing. So there were some minor tweaks from social care, but generally we're happy with it.
Nigel?
Andrew, thank you. Yeah, I've come across risk management in a business context, and I personally find it a very difficult subject to get my head around, and I was immensely impressed with this document, and yet I'm also very much in favour of Andy's points, because I think risk management only works if the organisation owns it, top down and bottom up, and I'm really encouraged to hear your ideas for sharing this document and perhaps allowing it, the DNA in it, to literally seep out into the organisation through a consultation process, because I suspect this is quite a new thing to this organisation. So I think it's imperative that we keep in mind our vision of being the best small country's independent healthcare service in the world. And I think, therefore, to slavishly refer to UK practices is not necessarily always the best thing, even if they are the best thing. I would be very encouraged, and I suspect the answer is yes, if you said we are looking at standards across the piece and we're taking the very best of them that we can find and we're applying them in context to the island and to Manx care. And I suspect that's what you're doing. And I suspect these UK references will be knocked out as part of your consultation process. So perhaps what we might do, Chairman, is approve this in principle to support the work that has gone on, and yet be aware of the need to perhaps Manxify it and to have it owned by the organisation and their hearts and minds as we go on to the next stage.
That is more or less what I was going to suggest. I think this is a really important piece of work. I wouldn't want to delay it. I think it is 98% fine. And if perhaps, I've actually sent one example to Paul where I've spotted a reference to the CQC in this, which isn't quite right. If anybody that's got any observations like this can send them to Paul, and perhaps we could have a circulation by email within 2 weeks of a version that's attended to those minor things. But we can say now that in principle we approve the document, and then we'll have something circulated within a couple of weeks. Does that sound reasonable?
I'd be happy with that compromise.
Okay.
Absolutely. Yeah.
Okay. Good. All right. Thank you.
The terms of reference, if I may give way to Andy. Andrew written these for us.
Thank you very much. So we've drawn up a set of terms of reference. It, I must point out for those who haven't spotted yet, it does have a word that needs changing. There is a reference to trust in there. We need to change that to Manx care. But otherwise it is a relatively comprehensive set of terms of reference with a wide-ranging purpose that will help to stimulate and sponsor risk management practice within the organisation. We believe that risk management is so important, it's relevant to bring the terms of reference here for the board to see and ratify. The exec team has already seen them and believe they're fit for purpose.
So I've got one comment that I'd like to make on this, which is the role of the committee in moderating risk scores. And I think you've heard me give the example before from my previous organisation where the catering department described a faulty dishwasher as a risk score of 25. And in the context of catering, it might feel like a 25, and in terms of the organisation overall, it was probably down about a sort of 4 or something like that. So if you're going to say that risk scoring 15 or more are escalated to the Manx Care Board, I think you need to have gone through a process to make sure that the over 15s are accurate. Indeed, they're all accurate. And I just didn't see a reference in the terms of reference to playing that moderating role.
That it is intended that the committee will do that.
Yeah.
And we'll look again to see how we can make sure that's more obvious to the reader.
Yeah. Okay, thanks. Any other? Andy?
Yeah, so in the risk document, it refers, I think, to those responsible for risk reporting through QSE and Audit Committee, as I recall. Is that right, Paul? I think in the main document?
Mm-hmm.
In here, this says basically this committee reports directly to the board, by the look of it, monitoring effectiveness.
Well, this committee...
That would be unusual.
Yeah, this committee is an executive committee of management. The CEO would normally escalate to the board any risk that she needs to believes need to be escalated. We've given the board the reservation of approval of the risk management policy, and in some cases this might be an appendix to a risk management policy so that you can see how it plays out. So we're trying to keep the two connected, but it is a committee of management.
Yeah, so it's not accountable to the board, but it will escalate risks to the board.
That's right.
Yeah.
And is that directly to the board rather than through either finance performance,
Yeah.
QSE?
It will come through the Chief Exec's monthly report.
Right, okay. Thank you.
Okay, so with that, I think we're happy to approve that. Board assurance framework?
Thank you, that one's fine. So we're at the beginning of a new financial year, and we talked about assurance against failure to achieve strategic objectives at the February workshop that we had. And the paper before you, which I'll assume colleagues have read, seeks to draw out the link between the 7 risks on the BAF that you had in 21-22. It makes connections with current operational risks, even though we do clearly flag in the paper that not all those risks have been appropriately challenged yet. We're not setting out to assure you that everything is perfect in terms of our risk management arrangements or our risk management practice or capacity. There's plenty of work to do, but we have connected this paper to the approval of the risk management policy and the terms of reference which you've just seen, and the arrangements which are being put in place to sponsor and improve risk management. I've tried to draw out 6 overarching strategic risks for the organisation for 22-23, which relate to the 22-23 objectives. And I'm hoping that there will be some coalescence around these risks, or perhaps with some tweaks, so that we can then go on to prepare a board assurance framework of the sort that you're used to seeing for 2 months' time. And I'm happy to take questions, Chair.
Okay, are there any? Andy?
Risk 1B, Manx Care does not provide safe services and continuously improve quality. That's ascribed to our Director of Social Care. Is this part of the rejigging of portfolios? Because I don't see the medical director on any of this, which is a bit of a surprise.
Are you talking about risk 1B from the 21-22?
Is that what okay. As at 18th of January 22.
Yeah,
Yeah.
That figure 1 relates to the previous
I
years.
apologise.
Sorry, I misread that.
Okay.
Thank you.
Any other comments on this?
Just that it's incredibly helpful.
And this has been through the management committee, the EMC, hasn't it, and approved that? Yeah.
Execs on last week.
Okay. Teresa?
Just in terms of, I guess, taking this forward, the Director of Nursing and I had a conversation last night, and it is really, really clear that there are lots of old risks, unvalidated, unreviewed risks in our system, and we would quite like to consider a proposal to work with the audit teams to actually start afresh with the new BAF headings, we recognise the risks that are identified in Figure 3. The Performance and Accountability Reviews has considered all of those during the course of the year. But I do think there is the opportunity with the new BAF, with the new risk approach that we've taken, with the new policy framework, to work with our audit teams to really do a fundamental refresh and start again on our risk registers, because I think we've got a lot of old risks, legacy risks just sat there that we need to do something with in a more formal and open and transparent way.
Sally?
Yeah, and I think that's really timely in CQC inspections as well.
So, Elaine, if I can just summarise on this agenda item for the minutes purposes. First of all, we received the update on quality governance, which we very warmly welcomed and endorsed. Secondly, we approve in principle the risk management policy, but invite anybody to send any comments about wording to Paul, and we have a circulation by email within a fortnight of the final version, which can then be approved by email. And thirdly, that we approve the terms of reference for the Risk Management Committee, and that we approve the BAF report that's here. Okay, thank you. Right, so we now move on to the update section. You've got my not very exciting set of updates about the fact that this is the 5th public meeting, and the places that I've been to see, and happily yesterday spent a day visiting social care institutions with Sally and most of the non-executives, which was really interesting. I also make a reference to the fact that we've been interviewing for the vacant non-executive director post. I can confirm that we have a preferred candidate who has been offered the job and accepted, but until we've gone through the formalities and so on, we can't really name that person. So hopefully by the time we meet next time, that person will be with us. Okay, so I'm handing over to you now, Teresa, for the bit on strategy development and then your general report.
Yes, thank you. Just in terms of strategy development, the board will be aware that for the first 2 years of Manx Care, we were required to provide a 1-year overview report, operating plan. But from next year, we will be required to develop a 3-year strategy for the organisation. I think we have covered this in some of our board development sessions. We have agreed a process and methodology for how we are going to do that. We are going to ask all of the care groups to do bottom-up integrated business planning, which will be led by the commissioning and contracting team, so Tammy Hewitt taking a lead on this. We have agreed, the methodology and the templating, and that will come to our Exec Management Committee on Friday of this week to launch that programme, with the expectation that we will develop the integrated business plans bottom up, an overarching strategy for the organisation which will cover 3 to 5 years, which will be coming to the board sort of towards the end of this calendar year for sign-off, launching into 23-24. So that work is underway.
Okay, so I think my one request for that is that it doesn't land to the board as a finished strategy at the end of the year, that we have at some point, part way through the year, the opportunity to just go through the work in progress and make any contributions to it.
I think it would be helpful to have this as a regular item through the board development sessions, just so we are shaping that collectively.
Yeah.
So is it planning to run alongside a 3-year budgetary plan as well?
I think
that was our next step, wasn't it, from the budgeting point of view?
Ideally, but I still don't think we have that confirmation as to whether we really will be managing a 3-year budget from next year or not. I think there are some discussions about being able to bring some resourcing forward to support transformation. But I think that's an ongoing discussion with DHSE and Treasury as to whether we really can have a 3-year budget from next year, which would, I think, be incredibly helpful.
I certainly would. Thank you.
If I could just come in on that. Yeah, I think you're right, Teresa, in terms of having a formally agreed 3 to 5 year budget process, that's not imminent because it sits so far outside of Treasury's current way of working. However, I think we've made a lot of progress in terms of agreeing some funding principles, and that Treasury has indicated it's willing to support but wouldn't commit to a figure at this point in time ahead of, so it's building on the growth business case that we prepared last year. So that principle has now been accepted by Treasury in terms of CPI plus growth as a general guide, and then there would be any specific business cases or requirements that we would seek specific funding for. So I think that's a really helpful step forward in terms of having a ballpark of what our settlement might look like until we can reach that procedural way of agreeing how a 3-year funding award would look.
Nigel?
Thanks, Andrew. Yeah, I'd just like to add to what Jackie's talked about. In fact, one of the things that I would like to talk about under finance and performance is actually our relationship with our stakeholders. And because I think this is incredibly important, in that accountants and businesses that report, services that report, tend to report in blocks, so either in calendar years or financial year ends to whatever. What we're very keen to do is to look at this as a rolling programme, so that when we finish one accounting point, say for example to the year ended 30th of April 2022, we're already actually looking forward 18 months and projecting on a monthly basis, so that we're constantly looking at this moving, living animal and accounting for it on that basis, because there are so many differing things that are affecting our results at any one time. Capital projects, projects that are coming to an end, projects that are growing, projects that need funding, projects that are saving money. And so we're looking at a moving piece all the time. It's like a rubric cube, and the only way you can really start to understand that is look at rolling projections. And that's an important part of, I think, the education and the trust that we need to engender with our stakeholders.
So I think the conclusion of that is that we support the process and timetable for development of a strategy, and whilst it would be ideal to have the 3-year funding alongside it, it looks less likely that we'll be able to do that this year, but maybe next year. Thank you. Okay, back to you for your wider report.
Thank you, and I'd just like to make sure people have the opportunity to appreciate and reflect on the Horizon scan, which absolutely details the extensive work that is going on in the care groups. Some really positive developments, and I'll highlight a couple. There are just a couple of areas of the report that I feel it's worth to just note to the board. Certainly with regards to COVID, when I wrote this report just over a week ago, we had 13 patients in hospital with COVID. As of this morning, we have 28, which just sort of gives an indication of how quickly this is moving. We absolutely do support the government's approach to managing COVID and the endemic approach that's been taken. But it does mean that given those COVID numbers, that is having an impact on us operationally in terms of the impact on some planned surgery. And also we are still suffering from very high levels of staff absence, so around 15% staff absence. And with that in mind, we've had to continue with the precautions and restrictions, and we made the difficult decision last week to cease visiting for a 2-week period in Nobles Hospital, in Ramsey District Cottage Hospital and in Manannan Court, just to be able to try and curtail the spread, which, as we know, this variant of COVID is very transmissible. But that said, I think our staff are doing an incredible job, and we are managing it, albeit the organisation has been consistently at sort of Opal 3 under severe pressure for the last 2 weeks. The Spring Booster programme has been launched, and I'd just like to thank the Director of Ops for all his work on this, and the launch of the antiviral programme, which started this week. I have referenced TT planning. I think it's acknowledged that we absolutely support this event. We are doing extensive planning in advance of the event, but I have flagged with Department of Health and Social Care the concerns just in terms of our operational context at this moment. So it will be very carefully monitored. We will be bringing updates through the executive team every week to make sure we are as prepared as we possibly can be. The context is we will be managing COVID alongside our planning for the TT. I just wanted to also flag under the quality and safety section that our radiation services, our imaging services were inspected by the UK Health Security Agency on the 22nd and 23rd of March. We are still awaiting the official report, but feedback on the day was incredibly positive. They saw lots of areas of good practice regarding our compliance with the ionising radiation protection regulations and IRMA. And also the Macmillan Quality Environment Mark report has come through, and we have maintained that strong position. As the Director of Nursing has already highlighted, we are in desperate need to be able to recruit to staff, and the executive team has spent time looking at the workforce profiles and have supported the expansion of the GTEC programme to be able to secure additional overseas nurses to respond to the current vacancy rates and the profiled workforce challenges over the next five years. So we would like to proceed immediately with recruiting to around 100 additional nurses, which is in line with our vacancy rate that we have. Just coming to the horizon scan, the points I would particularly like to highlight is that we are proceeding with the virtual vanguard for responding to the orthopaedic waiting list challenges, and that starts in a couple of weeks' time. We're very keen to protect that capacity, so we'll be working with an independent provider, Synaptic, in order to be able to bring the additional capacity onto the island, working in conjunction with our own teams. The Director of Ops will provide an update later on how well the other programmes have gone, and I would like to also mention that we will launch the Recovery College in mental health in conjunction with University College Isle of Man in a couple of weeks' time. So I think this is another very important development for mental health services, supporting early help and intervention and supporting recovery. So I'm happy to take any further comments or questions on my report.
Thank you, Peter. Does anybody have any? Well, I will come back to waiting lists when we get to the performance report, because I'm keen to know, so I'll give you advance notice, Oliver. I'm keen to know how we're doing against what we said we would be doing at the start of the year. I think we've put a presentation to Tinwald which showed what the waiting lists were at the beginning of the year and what we thought they would be by the end of the year, so I hope you'll give us an update at that stage on whether we're on track. And I do know, speaking to my former colleagues in the UK, that at the moment their waiting lists are just getting longer and longer and longer. So people that didn't refer themselves during the worst of the pandemic are now being referred, and the expectation there is that their waiting list will grow for as much as another 2 years. So we'll see how we compare. Okay, so I think well done, Teresa. Lots of good things to report in there. Struggle with COVID, of course, and struggle with a very high level of staff sickness absence, which is difficult because, of course, it puts even more strain on the ones who are here. But I think one can hope that as the weather improves, the disease might dissipate a bit. I don't know if I can ask a psychiatrist to give a prediction on what's going to happen with COVID. It's probably a bit unfair, wouldn't it? But I don't think anybody knows, frankly, but one can hope. Okay, so shall we move on to the reports from the committees? So we've got the order down here. So Sarah, quality, safety, engagement. Yep.
Thank you. We had a good meeting and just a couple of things to raise to the board. We have not been able to secure data from primary care providers into the serious incident log. I don't know if there's an update on that, Paul?
No, not at this stage.
No. And the Ockenden recommendations, we had quite a detailed discussion about what to do with the recommendations and came to the conclusion that we would like to identify those that can be achieved and delivered on, and those that require significant investment, and therefore whether that significant investment is what is the right thing to do for Manx Care or not. Really, obviously, recognising that the biggest recommendation in the Ockenden report is about relationships and culture, but there are some things that may require a business case to be taken forward. So we just want to have a much better understanding of where we are and what we're doing with those recommendations.
Chairman, would it help if I just made a comment about Ockenden? Because since Sarah has drafted this report, of course, there's been a further publication of a much more detailed report.
Yep.
And I think it would be prudent for this board to assess itself against each of those recommendations, because I suspect that our original thinking might be too limited and we need to broaden it out in light of the full knowledge that is now known about Ockenden. Because it will raise some questions around what kind of a maternity service we operate on the Isle of Man, with our limitations, with staffing, etc. But also I think there are some more fundamental questions around gaining assurance around the standards of practice, which I think are just as important for us. And I think if it's okay with you, we could do that piece of work and bring it back.
Yeah.
I think we are absolutely duty bound to do precisely that, because I think the Ockenden report suggests that a third or a quarter of trusts may have similar features to Shrewsbury and Telford, and that's not saying that we have got similar features, but we should do the work.
Yes, indeed. Absolutely.
Yeah.
An illustration, if you don't mind. Well, is the full Ockenden report available to every member of the public?
Yes.
Yeah.
Mm.
It's readily accessible? Because
Yes.
I did go through some the preliminary stuff, but
Yeah, no, it is. It's available
great.
to download.
Okay.
It's online in the public domain.
probably required reading for
It's a very detailed report. Now, if colleagues in the board have a chance, I would really encourage each and every one of us to read and digest it, because I think it will stimulate some thoughts around how we organise ourselves and what kind of quality governance mechanisms we would need. And also, taking on board the points that were raised earlier, there are some peculiarities around being an island and how we might organise a maternity service that need to be taken into consideration, because we don't have that mutual aid, mutual benefit relationship with other providers, because in England they may come to a view that they would close a maternity unit if they can't run it very well. That option won't be open to us. We would have to have an alternative way of thinking about that kind of problem. So if you can, I would encourage you to download it. If not, I can send it out. Have a good read. It's a really important document. And I think there's also a NHS providers summary, which I think we received, which you might find even easier to digest in terms of the main points. There's a lot to take on board there.
I have circulated that NHS providers report to non-executive directors. So, yeah.
Must be an email I haven't read yet.
Yeah. Well, it was only yesterday.
Oh, anyway.
Yep.
Thank you, Paul.
Thank you very much.
Just one additional thing, if I may. On Oliver's recommendation, we received a presentation from Dr. Catherine Rowe, which was absolutely brilliant. It was really inspiring. It took the place of where we may have received a patient story, and it brought to life the incredible creative and innovative work that's being done to assist people living with long-term conditions, and a lot around I think what we would refer to as sort of social prescribing, in terms of alternative ways of enabling people to live well, and it was absolutely fantastic. So maybe the board could hear from Dr. Rowe at some point in the future.
Sure. Yeah, well, we have a regular slot for such presentations. Okay, does that finish the Quality Committee?
Yes,
Shall we,
Chair.
Nigel, over to the Finance Committee?
Thank you, Andrew. Good morning, everybody, again. The Finance Performance and Commissioning Committee meets monthly, and we recently met on the 22nd of March. As ever, it is a long and lively meeting, and those of you who are not on the committee are very welcome to join us occasionally, even to see what we talk about and what we do. But we're actually going to change the format of the meeting, because we have struggled to get through the agenda in 3.5 hours. So we're going to look at breaking it down into sections, and maybe an earlier start and a later finish. But it's a big committee, and there's a lot to discuss. It will be no surprise to you that there are tensions still in our financial results, in our budgets, and looking forward. You know, anybody who is looking at the news right now can see that there are additional costs in the pipeline over which we have no control, not only in energy but also in supply chains. And actually, ironically, you know, the more efficient we get at dealing with the handling of some of our costs, it means that we're opening Pandora's box in some areas where we're dealing with contracts that perhaps haven't been touched for 2 or 3 years, and perhaps one of the results of that is that people will wake up to the fact that they're not charging us enough. So, you know, that is a sort of one issue that is coming out of actually our improvements, which will affect us, and we need to take account of. I'm not going to slavishly repeat the items in the report, but I would like to just raise one or two major points and put those in context. We've already touched on our stakeholder relationships, and I think this is going to be incredibly important and valuable going forward to seek to manage those relationships and communicate, particularly with Treasury and particularly with the Department, better, more regularly and more efficiently. Because I think there are instances where we're beginning to see within the management of Manx Care and certainly at Finance where we need to be making decisions quicker. We need to be identifying the issues and making those decisions quicker. And some of those decisions, because of the nature of the relationship we have with our stakeholders, need to be upstreamed to our stakeholders. And so we will be demanding that they too make decisions more quickly in order to enable us to achieve what we want to achieve. And I think that's an imperative that we're beginning to see. And I think that's very important because one of our colleagues describes this last financial year as a year of discovery. We didn't quite know where we started from, and we didn't quite know what we were going to inherit and get. And over that, we've had COVID and other challenges. So I think we now know what we've got better than ever, and we can look forward to that with confidence. But that too will demand that we define those financial parameters much more closely. And I think that's a very important role that the Finance and Performance Committee will be looking at as we go forward. The elephant in the room, of course, pay negotiations. We're funded up to 1%, and our colleagues have rejected 4%. So I think that is something that I want to escalate to the board. Those are the facts of the matter. I don't think there's anybody around this table that would wish not to reward people properly and sensibly going forward. But clearly, in terms of our monetary perspective and our budgets, finance and money is only one crude way in which we reward ourselves, but it is very important, and it's a very important measurement tool. So that does need raising. I think, to pick up one of your points, Andrew, we received a very encouraging report on the Restoration and Recovery Project and waiting list and how that money has been used and how that project has been going forward. And also some very encouraging reports around the emerging governance around performance. Much better grip and control around that, which has not yet translated into our figures. That work is ongoing. It's rather like a garden. You plant things, but we haven't quite seen them grow yet. But they're there and they're growing. So that was, I thought, very encouraging indeed. And of course, immense amount of work around a much more tooled up contract compliance team now, and some really, really good progress. So, some challenges, the overview of some challenges, some difficult things to manage, but I was immensely encouraged from our recent Finance Committee meeting.
Okay, thank you for that report. We'll move on to the People Committee now. Back to Sarah.
I don't really think I've got anything to add because Nigel's spoken about the key escalation issue, which is pay.
Yep.
Sorry, Sarah.
No, I mean, it's good, isn't it? It's showing that we're coming at this really important and difficult issue from different perspectives. We remain concerned about that and the implications of that. No, I've nothing to add, Chair, unless anyone's got any questions, of course.
Okay, well, I'll just keep ploughing ahead unless anybody sticks their hand up. So, as Katie is not with us today, Richard, you're going to do the Digital Committee.
Thank you, Chair. Good morning, everybody. So, the Digital and Informatics Committee meets every 2 months. We had a very full agenda at the last meeting, but there's 3 things that I need to, that Katie's asked me to bring here today. The first one is around the Manx Care Record. Now, the Manx Care Record Advisory Board, which is a group of people that includes a lot of clinicians from Manx Care, which is led by the Transformation Programme, that meets on a monthly basis and reports into the Digital Informatics Committee so that we understand progress. KPMG have done a report into the options for the Manx Care Record, and there were 5 options that were considered in the KPMG report. 2 of those options, option 4 and option 5, are the 2 options that are going to be brought forward to be looked at for the procurement of the Manx Care Record. Option 4 is a very broad electronic care record that covers a very broad spectrum of care settings. Option 5 is what they called really Option 4 Light, and that excludes primary care. There's been quite a lot of debate in the clinical workforce that they're fairly unanimous in their view that disconnect between primary care and secondary care is probably the most important risk that we need to cover, and not managing that well is probably the biggest barrier to integrated care. So that they wanted us to make sure that the board were aware that in their view Option 4 was the critical option from a clinical perspective. And also there was a very clear message that the solutions got to be clinically led, and that's something that Katie wanted me to also bring to the board. The second point is around information governance. KPMG again have done a report into information governance across the system, and it's clear that in order to bring the system into compliance, there's an awful lot of work that needs to be done. And the report talks about additional personnel on a temporary surge basis that will be required to assist with capacity issues to enable the attainment of compliance. And there was a discussion around that, and there's still some ambiguity around where the funding source for that additional surge activity is going to come from. And again, that's something that Katie wanted me to raise with the board. The final point is an issue around timing. So we've got a good 35 legacy systems in the IT estate in Manx Care across a wide variety of settings. As you may be aware, the Manx Care record, which is one of Jonathan's recommendations, has been on the cards for many years now, certainly before the pandemic. During the pandemic, there was a code freeze, a change freeze in IT, so it wasn't progressed during that period. And during the summer of 2021, once the transformation programme was starting to get back up to speed with the Manx Care record, it was very clear that legacy estate, some of those contracts were getting close to expiry, some of those systems were getting very close to end of life. So a piece of work was done with Cabinet Office to look at those contracts to see which systems we needed to keep and put contract expiries in, and to make sure that funding was in place to keep those systems going in advance of the arrival of the Manx Care record. So we worked with Treasury to put those waivers in place to make sure that we've got those extensions. And I think the risk that we wanted to raise today was that we need some clarity around the procurement timetable for the Manx Care record, because what we don't want to do is then run off the end of those contracts before the Manx Care record is ready for implementation.
Can I ask you a question about the procurement for the Manx Care record, which is that it's become apparent that Cheshire and Merseyside, which is our sort of key strategic partner for tertiary services and services that go off island, are developing a combined solution across the whole of Cheshire and Merseyside, possibly based on the EPIC system. How can we operate an open procurement with all potential suppliers when our key partner is going down a different route? I told you it wasn't an easy question.
No, I'm just not quite clear why would that prevent us?
Well, if we go to open procurement, we're saying we'll partner with anybody, and yet our key clinical partner is proceeding down the road with EPIC. Why would we not say, let's not bother with procurement, let's partner up with EPIC?
I would very much support that view. I personally think that's a company that's got some fabulous IT. It's one of very few companies that actually deliver IT across the entire scope of the Manx Care estate.
Including primary care.
Including primary care. It's something that you know, we're looking very carefully at all supplier options in that space, but I think there would be a huge advantage to partnering with Cheshire and Merseyside, that being our tertiary provider. And of course, if you have a single system that you're integrating to, well, you take an awful lot of those integration challenges away. So I mean, I would support that view, but of course the difficulties will be around the procurement approach that we take. Obviously, we need to follow the AG's advice in that, and make sure that we're following Treasury's financial regulations as we do so. But I think if we can navigate those things, I think that's something that we really do need to explore very seriously.
Okay, Teresa?
Yeah, I think a point which was made very strongly at the Digital and Information Committee, and I would want to just make sure the board is cited on this, is that for Manx Care, the option which does not fully align primary and secondary care is just not an option as far as we're concerned, and we were very clear on that, and I think we'll give some extremely clear messages into the transformation programme leading this. So the light option, as it's described, is just not really satisfactory. And so we must connect primary and secondary care. In fact, I went as far to say at the meeting that actually the functionality and the requirement of our Manx Care record has to really meet the requirements of the out-of-hospital space and social care in preference to hospital, which does need to be adequate, but actually so many of services for Manx Care need to be joined up in the out-of-hospital space. And because we don't have payment by results or some of those other functionalities which you would require from electronic patient record, I think that's where the compromise can be made. I also think it's a very important point to feed into that advisory board around that strategic partnership option. That must be one of the options that is progressed. So we can link in with the Cheshire and Mersey solution. That can't go off the table. Accepting all of the compromises around procurement and needing to get support from the AGs for that, it would make absolute sense if that ran in parallel with option 4.
Okay, thanks. And I think, from the nods around the table, we're all agreed that the integration with primary care is. I was speaking to a secondary care cardiologist yesterday who says that he does a weekend clinic for his cardiology patients. This is not on the Isle of Man. And he can now see the primary care record, so he can see all the drugs that his patients are being prescribed, which makes life so much easier to conduct a clinic like that, and vice versa. So.
And if we think about our strategy and where we would like and hope to be in 3 to 5 years, then absolutely that out-of-hospital functionality and integration is absolutely essential.
Sure. Andy?
Could you just come back to the Information Governance Advisory Board piece? And it says it mentions compliance. Does that mean to say that at the moment we can't actually comply with the current data regulations and so on? Is compliance in a different context here?
To be compliant with GDPR, there are a number of things that we need to do. Probably the one that is critical for us is having a real understanding of what information we process. And in order to be able to do that, we need to be able to have a record of processing activity, or a ROPA, as people would call that, under GDPR. And that's something that we need to have across everything that we do. So there needs to be these records of what it is that we process. And only then can we understand what information we're sharing and how we, as custodians of that information, how we're looking after it properly. And to have good rigour, that report has highlighted that we've got some gaps in those records. And I think that the surge activity talks about a couple of things. First of all, training people such that they understand those requirements, those regulatory requirements, and secondly, actually doing that work so that we do have those records and we do have those appropriate agreements in place.
And just how large is the financial implication of that? Have you any idea?
We haven't done that work.
Okay.
I personally think that would require a business case in order to be able to articulate it properly.
That's kind of what I'm thinking, because it doesn't sound cheap to,
It is substantial.
to deal with that.
It is substantial. Several £100,000 pounds worth of
assuming it would be.
resource.
Thanks for the clarification.
Can I just clarify, coming back to the Manx Care record and the question around procurement, is it transformation who will be leading and driving that procurement, or is that something that Manx Care will be doing?
That's the Cabinet Office will be leading and doing that procurement, and I believe it becomes a Manx Care responsibility at implementation.
Yeah, there's a sort of jointly chaired committee which is currently sort of more chaired by the transformation team, but once we've got a procurement, then it'll be more chaired by Teresa.
Yeah. Okay. So it's absolutely critical then that the people leading the procurement are absolutely cited and aligned on what our
Absolutely.
Yeah.
aspirations are.
But I think what that discussion reveals is quite a big strategic choice to be made about whether to go ahead with a procurement of any provider to a preferred procurement with EPIC, and that's going to have to be addressed with AGs. Yep.
So I spoke to Northern Ireland, their board look after, is it 5 or 6 very large trusts in Northern Ireland, and they've gone with a single solution, so they've effectively gone for, they've gone with EPIC. And I spoke to them about their procurement approach, and they said the only way to be able to procure such a wide range system when there's so few vendors was through a competitive dialogue approach. And that's something certainly that DHSC have been advocating at the advisory board, is that we seriously look at a competitive dialogue approach.
Okay. Right, thank you for that report. Let's go on to the last, which is audit. Andy.
There's only one thing to basically raise, which is coming at what we've already heard from 2 separate pieces about data sharing. And at audit committee we effectively heard that trying to satisfy the data commissioner about the robustness of our arrangements is actually hampering and is likely to hamper progress, particularly in the integrated care space, which is absolutely dead in our sights for our requirements for this year. We have to make progress, and therefore that's the only thing which we could see particularly would be a very, very large obstacle to get over, and we need to get over it quickly. I'm not quite sure what approach we should take, but I guess Teresa will probably have a few ideas.
Well, I think we've got a meeting scheduled with the ICO in the next 2 or 3 weeks, and I think we need to. I mean, and they are sat on our advisory board, so we do have their expertise and advice into the advisory board. You know, I think what we need to try and convey is a level of cooperation, so they understand the context in which we're working, but then we work with them. They would rather know things in advance and work with us through that journey. And I think we do start on the back foot a little bit, but I'm hoping that the meeting we have in the next couple of weeks, where we share a wider set of plans and a route to compliance, which we'll discuss at the advisory board tomorrow, will start to reshape that relationship with the ICO. But I do acknowledge it's incredibly challenging and has all the potential of stopping us really proceeding with the level of integration that we all hope and aspire to, and the reason why Manx Care was fundamentally established. But I'm confident we can work through that.
And would you be happy if we just brought that back to the audit committee in a couple of months, just to check to make sure that we are making adequate progress?
Yeah, absolutely. I think that whole journey to information governance, compliance and data sharing is one of our key risks and our key priorities to resolve in the next few weeks.
Thank you.
Okay, now we're a bit ahead of ourselves in terms of time, but I propose to plough on until we get to 11 o'clock and have a break then. Now, before we go into the next section, I just want to remind everybody that we've shifted the date of the board. So instead of being the last week of the month, it's now the first week of the following month, in order that we can receive the up-to-date performance and finance reports. Now, you will have noticed that in this month's we haven't got the update performance and finance reports, but I think reassured that by next time we will have. So, Oliver, it's fine for you to talk about this ancient piece of history, which is the January Integrated Performance Report. Please give us any highlights from it.
Well, I wasn't going to really go through much in terms of the report, just because there's really comprehensive narrative that has been provided by the care groups. The only thing I was going to mention as a good news story was around our NHS dental waiting list. So, you know, the size of our dental waiting list has been a matter of note over the last few months. But I'm glad to say that following positive discussions with our NHS dental contractors, we anticipate that the individuals who are waiting to be assigned an NHS dentist, which is around 2,000 people, will receive an allocation for an NHS dentist within the next 3 to 6 months. And that will leave 1,000 places to be allocated to. So the next 1,000 people who wish to take up the offer of an NHS dentist will get placed, which is a really good development, thanks to some really positive contractual discussions that have taken place between our primary care team and the dental contractors.
Good, thank you. Okay, any questions about the integrated performance report? Yep, sure. So as usual, Sally, do you want to give highlights from social care?
There's only two things I really wanted to highlight. One, within adult social work, assessments seem very low, but it is in the narrative. Going to the wellbeing hub model, we've actually changed the assessment so that it's a single assessment across all agencies. Social work used to have its own assessment and was quite bedded to that, but we've worked through that. And despite assurances that our Rio system would be able to cope with and still give us the same data, it hasn't. So we're still working through. So the numbers that are recorded in assessments been done on time, both for individuals and the carers, is exceptionally low this time, but we're working through that with the BI team. The other thing was just from our visits yesterday, Andrew, just to again assure you the numbers of people are respite. I know that you were led to believe that, you know, there was a real issue with respite. Yeah. And our percentage of respite that's actually taken up rarely hits 60%. Now, taking that with the caveat that obviously we've had outbreaks of COVID within homes, so we wouldn't be taking people in, we've had staff in, but there still is quite a capacity there. And some of that is because of the unfit state of some of the, well, two of our homes, in terms of, you know, not having ensuite facilities, not reaching registration requirements any longer.
So just to highlight that, we had been told that it was, quote, almost impossible to gain access to respite care. And yesterday, some of us visited the Southlands care home and found there 5 respite care beds, none of which were, well, some of which were not full. And the fact is that it may not be possible to provide respite care in every corner of the island, but it can be made available in parts of the island, and it was reassuring to hear that yesterday. Yep.
And it seems to be better managed now. That is going directly through the wellbeing hubs and not having to go through social work.
Sure, sure. I mean, I think, Oliver, if I can, I think it was in the West that I was told that there was no access to respite care at all. Not by you personally, but were you aware that there are in fact beds available in the South?
I hadn't asked the question recently, but no, I wasn't aware of that.
Right. Okay. So. Right. Okay. No more questions. So we'll move on to update on the verbal update on the ROF.
Yes. So the mandate assurance report is in your pack. This is a detailed report which was provided to the Department of Health and Social Care in support of our mandate assurance meeting, which was last week. We will be providing a further full Q4 update on the ROF to the board in May, but this was for the purposes of reporting our close to end of year position to the DHSC. It covers a response against the 12 mandate objectives for 21-22. As you can see, the report identifies the progress that we have made during the course of the year, the key risks and challenges for each of those mandate objectives, and also some of the plans we have moving forward. Because we have had a great deal of engagement in the mandate preparations for 22-23 and have received that, a lot of this work naturally continues. So we are currently developing our ROF for 22-23, reflecting the mandate objectives set, and that will go through a governance piece during the next 4 weeks and come back to the board in May for final sign-off. I think, you know, I'm comfortable that we have made really good progress against the mandate objectives. A number of areas are green, where we have made good progress and delivered against all of the requirements. There are some areas of amber. I think the feedback from the Department of Health and Social Care is that they would like to see us make more progress in primary care at scale. They do acknowledge the challenges we have around the data sharing issue, which has sort of been a little bit of a barrier in all of that, and integrated care. But again, I think we are making some really good progress here. Appendix A of the report details the area where we rated ourselves red. That is in finance and delivery of the CIP, and there is a very detailed appendix which, as we've discussed here at board many times, the very difficult inherited position we had at the start of the year, a series of additional financial challenges during the course of the year, and all of that required us to seek a supplementary vote. So I won't go through the appendix because I think we've covered most of this in the board during the course of the year. But the detail is there to identify how that £10 million overspend was achieved or not achieved, or how we got into that position. So I'm happy to take any comments on the mandate assurance report, but I think there was a positive response from DHSC reflecting the amount of work that the Manx care teams have done to prepare this report and respond to the mandate for 21-22.
We will be getting to the supplementary vote issue just a little bit further down the agenda.
We will.
So if we can leave it for that for now. Okay. Yes, Andy.
Just a couple of minor things. I was a little bit surprised to see the improved complaints management and the MCALs as amber, because I know Paul and Shree worked extremely hard to bring the complaints responses bang up to date, which seems to be working very well. And I thought that might actually have tipped that over into green. And similarly, MCALs has been from scratch and seems to have been very successful.
Well, I think I'd agree with you about MCALs. I think our ambition for these two elements is higher. We want to get a much more responsive approach to complaints, and although we're making good progress in that regard, I don't think we're where we want to be at this stage.
So this is more about being absolutely self-critical.
It's reflecting our ambition for,
Fine, absolutely.
something that we want to be great about.
That's very good. Thank you very much.
I think that's a mixture of the timeliness of response to complaints and the quality of the response letters, both of which we want to improve, isn't it? Yeah. Did I see a hand? No, I didn't. I imagined a hand. Sorry. Okay, let's move on to my favourite topic then, the restoration and recovery update, Oliver.
So as we've mentioned a few times in previous board meetings, we're lucky enough to receive 1.84 million from the Treasury as part of our initial bid around recovery and restoration, and that was split across 4 areas: endoscopy, cataracts, outpatients and mental health. In terms of endoscopy, we've used that funding to increase our own in-house capacity on an interim basis, and we're able to deliver an additional 458 procedures, which actually cleared the waiting list, and we cleared the waiting list at the end of February. We have accrued, because of sickness and some absence during March, have accrued a further 98 onto that waiting list. But I've been provided with plans by the team that they're going to have that reduced back to 0 within 5 weeks. In terms of cataracts, we've, as Teresa mentioned earlier, we've contracted with a company called Synaptic to deliver 350 cataract procedures. We've delivered so far 150 of those, and we're due to have another 200 done over the next, or by the end of June. The issue with cataracts is that we started with quite a considerable waiting list, and we have on average 70 cataracts added to the waiting list every month, which means that even with once we've completed the 350 procedures that have been contracted through Synaptic, we still have just under 1,300 on the waiting list. So as part of the next phase of the recovery and restoration business case, which we'll be submitting to the business case review group this month on the 20th, we're looking for to commission a further 2,400 cases through Synaptic, which at the rate of 150 a month would clear the waiting list by October 23. And that would get us to a position
Can you
of...
check, you mean October 23?
Yeah.
Yeah, okay.
Because of the additions, we're actually only, even if we're doing 150 a month, we're actually only taking off 80 from the waiting list.
Okay.
But clearly there is a bigger piece of work that we need to do around what our cataract service is long term, because clearly we can't, be using them to blitz our waiting list and then end up accruing further. So we do need a more permanent solution to enable us to undertake 70 cataracts per month, permanently. From an outpatient point of view, we're using a company called, we're using a combination of our own in-house capacity increases and a company called Medifer, which is a virtual outpatient consultation service. Medifer started phase 1 of its rollout, which is within the specialties of cardiology, respiratory, gastro, ENT and dermatology. And we started those in March. And phase 2 is orthopaedics and pain services, which is due to start in July. We've also for some specialties, commissioned some additional in-house capacity. So, for example, in neurology, our neurologist that visits from Walton, Dr. Bracewell, on a weekly basis, has been doing some additional sessions for us. And we anticipate that by August, the neurology waiting list will be reduced down to 0, and we'll be in a position then to maintain the neurology waiting list just using our baseline capacity. But from a Medifer point of view, we've commissioned just over 3,000 new outpatient appointments from them. From a mental health point of view, you'll have seen in the news last week that we've have finally completed our contractual negotiations and sign off with Minds Matter to deliver 157 courses of treatment for the CAMS service, Children and Adolescent Mental Health Services, and they are going to be starting in April. So that's 157 patients, and each patient gets 12 appointments, so 12 appointments with either a psychologist or a counsellor, which will make a huge impact on our CAMS waiting list. And finally, in terms of hip and knee activity, outside of the 1.84 million that we secured from the first restoration recovery business case, we secured another $1 million for predominantly dedicated for hip and knee replacements, which we are again using Synaptic to undertake. So we started, our initial waiting list for hip and knee at the moment is 448 patients. We're going to be doing for this initial phase of so for the £1 million contract, we're going to be doing 426 procedures over the next 7 months. And as Teresa mentioned, that is a combination of Synaptic staff working with our own surgeons to actually deliver that activity, and some of the activity will also be delivered by Synaptic surgeons themselves. So it's a combination of a kind of blended staffing model. So that brings us down to a balance of, once the first phase is completed, which is in early December, that brings us down to a waiting list of 248. And so we're including in the second business case for restoration recovery a further 400 cases that will take us down to a waiting list of 13 patients by May of next year. and by which time, once we've got down to that level of waiting list, we will have enough to cover our own, our demand and capacity will match by then, so we will no longer need any external support because our own resources will be able to cover that. And I think that was it.
That's my question. So can I just repeat my question then? We made a series of projections to Tynwald in January of this year.
Yeah.
Are we on track to achieve those?
Yeah.
We are on track, right. Okay, thanks. Teresa?
Yes, I'd just like to make a couple of, I guess, important points to supplement what Oliver has said. This is additional capacity, and I think it's really important that we identify that where possible, we are maintaining services on island. So we are bringing people across to the island to help us respond to our waiting times. We know when we've had to transfer patients off island, the uptake is quite low, and there are all the logistical issues of having to go off island. So whilst we did that in response to the breast 2-week wait issue, for example, last summer, we know it's not ideal. So I think it's really positive that we have been able to bring this capacity onto the island to treat people locally within their local hospital. The second point that I would like to make is that this is, where possible, we will use our own clinicians to deliver this additional capacity and activity. And I think endoscopy is the clear example of that. We must make sure we are delivering value for money. We have a responsibility to the taxpayer to make sure that when we are receiving this additional restoration and recovery funding, we are absolutely getting good value for money for that, and we are responding to the waiting list challenges. But this is absolutely our teams fully utilised, working in conjunction with the additionality that we are providing into the system. And I think those are just two very important points that I wanted to make in conjunction with those 3 areas of restoration and recovery.
Can I just say one more thing? Teresa just reminded me about something that, you know, clearly there's a huge amount of money and effort gone into this piece of work, but it is quite easy to think that we have a real blitz on our waiting list, and then we kind of slide into where we were, into kind of a not a great position in the next few years. But in the background we have a number of people working on our long-term demand and capacity piece. So that actually, when we were talking just before around orthopaedics, that actually we know that there is, once we've got rid of the waiting list, actually our baseline capacity is enough to maintain the amount of demand that we're getting through referrals and additions to the waiting list. And that piece of work is happening across all specialties, so that we actually, as part of the more long-term demand and capacity planning, that we know that there is enough capacity within our baseline in order to satisfy the demand that we're getting. Otherwise, we will just need to keep going back to Treasury for more money every so often for additional capacity to blitz our waiting list, and that's the position that we don't want to be in. So I think this is although there is a lot of money that has gone into the system, and a lot of money that we will be requesting in the future from Treasury in order to be able to get us back to a square one, essentially. The fact that we are going to be planning in order to match our staff capacity for the future is really important.
Speaking of Treasury, Jackie, you wanted to come in?
Yeah, thanks. It was just reflecting on the journey of that particular business case, from how we initially assessed or perceived that we would deliver this additional capacity to the way that it's being delivered now. And I think that the team encountered quite a few roadblocks and curveballs along the way, with providers indicating availability and then shooting up the prices and all sorts of things. And I think it's important to recognise the efforts of the team in remaining completely focused on delivering not only best value for money, but also the best solution. And I think actually the model that has been arrived at now, with that partnership between an external provider providing additional capacity and top up to support our internal capacity, is a really powerful model. And so I'm really pleased to see that work. I think in other instances, there would have been the temptation to say that the provider has increased the price by 20%, we're just going to pay the 20%, but the team absolutely wouldn't do that, and they sought for better. And I think it's also worth mentioning that the mental health capacity that Oliver mentioned earlier was not actually part of the original plan. So again, it's through the efforts of the team in terms of remaining focused on that value for money that they've been able to deliver some additional activity within that envelope. I would say that there's obviously because of those challenges, the delivery timescale has slipped somewhat from what we had initially anticipated. And the funding was agreed for this financial year, so there's a paper with Treasury at the moment to just secure the remainder of that funding across into next year, and explaining where we're at with all of those. But I just wanted to add that additional context because the team has been really impressed by what the team has just had to put up with, for want of a better phrase, in trying to deliver this.
So essentially the story is that there is a plan which is being implemented to get rid of the hump that's grown in the waiting lists, and then beyond that there's a plan to have the capacity to maintain the waiting lists at their new level.
Yeah.
What I would like to give you the challenge back is to report that to us as a board so that we can see the plan and how it's being implemented, and we can say that in December 2022 and December, what will be the waiting list be, what will be the waiting time be, because I think that's what matters to people, is how long will that wait be. So can I leave you with that challenge?
Yep.
For the future? Thank you. Andy.
Just a very, very brief comment, just to say, I think we owe a big debt of gratitude to the Treasury for following us on this, and a huge debt of gratitude to our execs for what seems to be an absolutely terrific piece of work to put us in a far more enviable position than the UK.
Yep, absolutely. That's the point I made earlier on, that the UK expects waiting lists to keep on growing for nearly another 2 years.
Very, very good indeed.
Sure. Good. Right, well, it's nearly 11 o'clock, and that seems to me to be a sensible point to have a break. So if we come back in about 10 minutes, we'll conclude the rest of the agenda. Thanks, everybody. for an hour for that break. So if I go on to culture, Anne, would you like to do your report?
Apologies for the sort was late. I think it was circulated out of the agenda.
Yep.
But essentially I just wanted to highlight to the board that the 2-year milestone plan has now been agreed for the workforce and culture team. That's been agreed by the transformation team in consultation with Manx Care, and they're working at the moment on refining the actions that sit under that plan, and that might also feed into developments of year 2. I think Teresa's report outlined some of the priorities for next year, which are around workforce planning, care values and recruitment. And I thought I've also outlined some of the current pieces of work the team are involved with.
Okay, thank you. Any questions for Anne? Go on then.
So just to supplement Anne's report, is that we had been working with the BMA on a cultural survey which was conducted during March, and we've just got the results of that. So we had a session with the BMA and the reps yesterday afternoon just to walk through the report. You know, I think we need to have a very clear, defined response by the board to it. So over the next 2 or 3 weeks, we'll be working with the care groups and workforce and culture team who have agreed to support facilitated sessions to action plan in response to the BMA survey. You know, it's not a great read, but we always acknowledged it would be a very good baseline from which we then would take forward improvements around medical engagement. And I think a very clear response from this board with some clear actions that we can monitor during the course of the year would be beneficial to come back next time via the People Committee, I think so.
Yes, please, I'm sure. So, thank you. Right, on to financial matters. Jackie, over to you.
Thank you very much, Chair. So you'll have received in your pack the January management accounts. As Chair mentioned earlier, we're anticipating moving to having prior month accounts going forward. I do have the February figures as normal, so I'll provide an update on the latest position. But just talking through January, a couple of key points to highlight is that there was a movement in the month, a negative movement of 2 million. Part of that was to do with the revised pay award that was offered in December, January time. So that increased. And then also during January, we've mentioned a number of times about the sickness absence rates being experienced across the system. There was a particular peak in that during January, so some additional cost was incurred in order to provide coverage for essential services, and that amounted to an amount of about 860k. So that's been added to the January figure, and that contributes to the 2 million movement. However, that amount was included in our final end-of-year Q4 fund claim to Treasury around COVID costs, and I'm pleased to say that that Q4 funding request has been agreed and concurred to by Treasury, so that's really, really positive news. Staying on the subject of COVID, we also submitted our Q1 estimate of what our COVID costs would be. And again, Treasury, by and large, concurred to that amount with some adjustments. So we're just working through with Treasury what those adjustments are. Inevitably, they've been downwards, but our estimates were always on the conservative side anyway, with always an ambition to come in at less than what we'd anticipated, but we were presenting a worst-case scenario figure. So
just on that, Jackie, so we're now in Q1.
Yeah.
What are we spending on COVID now?
I'm not sure what the monthly run rate on COVID is.
No, I don't mean the money. I mean what items have we?
So at the moment, there's sickness absence is a big one, vaccination, swabbing, and the 111 team. They will be the key, and LFDs. They're the big key areas. So what we're finding is that a lot of the mitigations that we put in place in 21-22 have kind of fallen away, and we've been able to mitigate a lot of those. A lot of the lost income that we experienced in 21-22, we'd expect that to recover. But obviously we maintain a very close eye on it, and if things start to move in a direction, because as Teresa said before, it's still a very, very fluid situation. So the lines of communication are open with the department and with Treasury about giving as much advance foresight as possible if we think that that's going to move significantly.
So once the case numbers begin to come down, one can anticipate that all of those areas of expenditure will begin to reduce as well.
Yeah.
But I think from what we're saying at the moment, the numbers are not coming down. The numbers are...
No, the numbers definitely aren't coming down in terms of the number of hospital admissions. The overall transmission in the community is starting to decline now. I think that will be temporary. What we anticipate is that we will start to see the numbers rise again when people come back from their Easter break. So we might have a short period of declining with a period of increased numbers during the latter part of April going into the early part of May, which is what we'll be monitoring really closely.
Yeah. So as I say, that's an ongoing situation in terms of closely monitoring that spend. I think Treasury's view and ambition is that as we move through the year, and as hopefully this becomes less and less of an issue for us.
I think that was the view this time last year as well.
Yeah, exactly. Yeah. So we always maintain the ambition that at some point this will become business as usual. But there's likely to reach a point at which we assess, is there a business as usual underlying requirement for vaccinations, for example, or additional PPE or additional swabbing? And when we reach a point where we think that becomes part of our ongoing underlying business as usual, then there's a conversation to be had about how that's funded. At the moment, it's just done on an emergency basis. So just coming back to January's management accounts, just on terms of the SIP, so obviously our target for the year is 2.7 million, obviously due to various delays, again sickness absence during November, December and January, and the pharmacy team really hit that programme hard because they were the biggest deliverer of savings. So the estimate was reduced to 1.7. I'm pleased to report that in January we achieved 1.6, and looking at February's numbers, the gross saving is currently at 1.8. So when we take off the programme management costs, we look set to meet that 1.7 million that's in the forecast, which is really encouraging. And then I think the other thing to mention on February's position is that it has remained largely the same as January's position. There haven't been any big movements, which is reassuring as we reach the end of the year. We tried really hard during December and January to try and flush out as much of the risks that we could quantify in support of the supplementary vote. So we remain quietly confident as we come to the end of the year. So the supplementary vote, as we mentioned, was approved. So what we're doing now, the focus now will really be on, as we come to the end of, obviously the year end is now past, is now pulling together all of those various funding streams with the various fund claims that we've been fortunate enough to receive during the year. And now there's just a tallying up exercise to make sure that we align the costs to the appropriate pots first. So perhaps just to explain to the board in terms of the way that the order in which we're supposed to do it is, we need to utilise the full 10 million first, and then anything else goes into fund claims for various specific things. So there's a bit of moving things about, moving deck chairs about the place. But that's, I think, what we plan to do is at the end, when we've done all of that, is to produce not just the final financial position against budget, but the final total position against all of the fund claims, so we can get that total picture of what the entire spend is and where it's all happened.
So your expectation at the moment is that, taking into account the supplementary vote, we will be in balance for the year just ended?
Mm-hmm.
Yeah.
Yeah, I think I need to highlight that there still remains a potential risk around the 21-22 pay award.
Sure. Okay.
So what we've included in there is the offer that we've made.
Okay, any questions for Jackie? And have you covered there what you wanted to say about the supplementary vote? Yeah,
so as I say, the paper details is basically the presentation that the Minister used when he delivered his speech for the supplementary vote. Not much else to add to that.
Okay, well, looks like there's no more questions, so we are zooming through the business today. So nobody gave notice of any other business, so there isn't any. Now, We may be short on numbers of members of the public, but we're not short on questions from members of the public. Mr. Mann has done his usual and supplied us with a large number of questions, which fortunately we've got time to go through, so I will do my best to answer them. So the first question was, as the police have recently indicated their loss of working hours through mental illness and stress, could Manx Care please provide the same details with a breakdown between hospital and primary care services? And the answer is not broken down between hospital and primary care services. I don't know whether we could have done that. Is that?
No, the constabulary break their organisation down into the constabulary and fire and rescue. Manx Care break our organisation down into care groups, and those care groups could be based, they will have staff based in the hospital and outside the hospital. So it's not possible to just report on hospitals because we're sort of limited by how we've set up our organisation in our software.
The reason why I asked the question is that, of course, the number of man-hours lost in the different divisions of the organisation is very indicative of particularly the stresses and so on at those particular divisions. You can have a large organisation and some of them won't be so badly affected, but it's a good reflection of where the main problems are within the organisation. I've seen within the board papers, I think it's about a 2.3% overall percentage of workplace loss through stress, depression and mental illness. But that's not very helpful, because if, for argument's sake, it was all focused on one emergency department or something like that, the organisation would be aware that it was a critical issue in that particular area. And at the moment, the figures aren't telling us anything.
So the People Committee does take a report on sickness absence across the organisation and broken down by department to do precisely what you say. And I don't see any harm in having that information made more publicly available. But the answer to the question that you've posed is that Manx Care lost 2,671 days to work-related stress and 6,834 days to personal stress in the 9 months to December 2021. And that, in terms of percentage, works out at about 17% of personal stress and 7% of work-related stress, if I read this right. Should we move on to your second question? If you've got any clarification, could I? Well, I suggest you just grab Anne at the end of this, because she's our expert on this. Second question: could Manx Care please provide an update and progress report on the modernisation, renewal and refit of the Nobles A&E department, including confirmation that it's fully funded, and also whether the public can expect any element of it to have been paid for by private donation and or substantive contribution from individuals or entities associated with the gambling industry. Answer: we've now been advised that we're to submit a business case to Treasury for funding the ED refurbishment following the normal capital process. The design is complete, the business case is currently being developed for agreement with the DHSC and onward to Treasury with a view to funding from April 2023. So the answer is when? 2023, and no, the funding is coming from the Treasury. Okay. Next question, could Manx Care provide an up-to-date progress report on the replacement, renewal and modernisation of the current GP surgery in Ramsey with a modern state-of-the-art medical centre together with a timeline for provision of the same? The answer we've got is that the Ramsey GP surgery is privately owned by the GPs in Ramsey, and there has been no approach to Manx Care to provide an alternative surgery, and just to note that the Ramsey GPs also use the GP surgery at Derby. Well, I think the answer is no. There is no proposal.
I'm asking, has Manx Care actually taken some steps itself to replace that surgery? Not that the GPs are choosing to.
Right, well...
It's the duty of this board, surely, to provide a decent facility in the north of the island, and it's not currently there.
I think the person that has provided the answer is Barbara Scott, who unfortunately is on leave today. And again, we can ask her to give further clarification unless, Teresa, you think you can, but I don't think it is our responsibility.
No, it's not our responsibility. It is the GPs as contractors to approach us if they need assistance with that, but and they haven't. We are looking more broadly with the Northern Wellbeing Partnership about and the use of the Ramsey Hospital estate in a broader set of strategic aims around how we provide comprehensive services to the north of the island. But that will be a programme which evolves during the next 6 months, taking into account, say, Ramsey District Cottage Hospital, making the best use of that facility, the Wellbeing Partnership, but also how we use the GP practice who are engaged in that work as well.
But that's not actually replacing doctor surgery, which is what this actually
It's not. It's a comprehensive consideration about how we provide comprehensive services to the north of the island, including the use of the existing estate in its best format.
That practice has admitted that they're struggling, that they're taking over 500 calls per day and they can't cope. So surely somebody has to step in and provide the service to the public in the north of the island is required. We can't, just to say that the doctors are dictating or that it's over to them isn't answering the problem to a large number of people, residents of the north.
I think the difference is that all the rest of the GP premises are owned by DHSC. That one is unique in being owned by its own doctors.
But there's nothing to stop Manx Care or the department now providing a new facility and effectively leaving the GPs with their old premises. They want to keep it fine, but it's not fit for purpose for the people of the north of the island. It hasn't been for a number of years.
Okay, so well, you've made your point.
I'd urge some rethinking on it, Mr. Chairman, please.
You've made your point, and we will hear it, and I will ask Barbara what their prioritisation is. Next question is, could Manx Care please confirm the current, brackets April 22, waiting times for operations in all main areas of expertise, and what additional funding has been sought from Treasury to alleviate the suffering of patients waiting on the list? I mean, I think you heard from Oliver earlier on a quite comprehensive update on where we are on that. I have got some answers here. I don't propose to read out 257 days for ENT, 284. We can send you this, all right. It's just a table of figures, which is not going to be very productive.
As a start table of figures, Mr. Chairman, I would actually be grateful if everybody in this room was made fully aware of what that position actually is.
Yes, and I think in the discussion that we previously had, Oliver gave a headline, and I've asked for the next board to be provided with a routine report on the progress against the commitments that have been given.
Because each one of those figures, Mr. Chairman, is a human being suffering at the moment.
Yep. And I think we know that. We know that the waiting list has grown considerably because of coronavirus, and we know that we're doing considerably better than the UK in reducing those waiting lists. So I'll move on to the next one. Could Manx Care please confirm the total number of GP appointments lost across the island for each of the GP training days taken during 2021-22? The answer from the relevant managers, it's not possible to provide the number of appointments lost during each of the training days without taking into account the additional appointments which are provided by practices before and after the education sessions, both in the week itself and the weeks before and after. Routine appointments are not offered on these half-day sessions. However, emergency appointments are available with the on-call GP for those patients who need urgent medical care.
So effectively, nobody's prepared to do the calculations to how many 10-minute appointments are lost in every GP surgery across the island, while the doctors take the time out of the working day to do their training. It's a colossal loss, Mr. Chairman, across the whole island.
I'm sure you would want your doctors to be trained and kept up to date, which is...
Yes, but every other profession, Mr. Chairman, does their CPD in their own time, or on the weekend or in the evening.
No, that's not correct, I'm afraid. The consultant contract explicitly provides that hospital doctors have timetable time to do professional development.
Could they not do them in the evening, or could they not do them on a Saturday?
I think it is normal nowadays to give people a work-life balance where they're not expected to work evenings and weekends unless they want to. You've made your point, but it's not in line with the contractual arrangements for either hospital or primary care doctors. Next one is, as the questioner has just taken in excess of 10 days to achieve a repeat prescription, could Manx Care please indicate whether GPs can be given discretion to prescribe more than 1 month's supply of medication where the mental well-being of the patient is not in question and where the medication prescribed is of a long-term permanent nature? Answer, yes. This policy already exists and already many patients benefit from 2 monthly prescriptions.
So I can go back to the doctor and ask him why he can't do it then, because there seems to be that there's a problem with it across the whole island.
I don't know about your personal case, and it's probably not appropriate for me to go into it, but anyway, the policy does exist for longer term prescriptions to be given. Next one, could Manx Care please indicate who is the new primary healthcare individual dictating the recommended level of thyroxine to GP surgeries and thus removing the discretion of GPs to prescribe as they wish? Could Manx Care also confirm whether the recommended dosages currently being used are those recommended purely by that one individual, by the UK or by an entity further afield? The answer is any prescriptions that come to Manx Care specialities within their domain of practice will be optimised accordingly. The endocrinology consultant follows guidance by professional bodies in management and treatment of all his patients, including patients with thyroid disorder. GPs will have communication regarding the reasons behind any change of medication or dosage.
So the actual level, Mr. Chairman, is being set on the island by the...
Following guidance by professional bodies.
Is that a UK body or an American body? Which figure?
It would be a UK body. It would be a UK body. Still a few to go. Given the current high level of COVID transmission, will Manx Care explain why these cases are not being isolated away from the main body of Nobles Hospital in Ward 20 or Ramsey Cottage Hospital, thus compromising the operational capacity of the island's main hospital? The answer is that treatment of patients with COVID has to take place within the main hospital building, as this is the location of medical and nursing teams and diagnostic equipment. Managing acutely unwell patients outside of the main hospital building would result in a reduced level of coverage, particularly by medical teams, and a requirement for transport of patients to the main building should they require an imaging procedure or a surgical procedure. So basically it's to keep all the resources in one place.
And to keep people safe.
And to keep people safe. Come.
Compromising the operational capacity of the hospital in the process.
Well, you have a choice between compromising the safety of those patients, putting them in a separate place, or, as we do know, the operational capacity has been reduced, and that's why there is all this work going into reducing the waiting list.
Didn't the island spend a large sum of money converting the Pullman Newlands Ward 20 specifically to isolate the COVID patients away from the main body of the hospital? It seems that's now not being used.
Oliver, do you want to answer about that?
We did. That was when we were in a situation where we had most of our services scaled down or stopped. So when we had Ward 20 open to accommodate the patients who were relocated for Abbotswood, we had them looked after by health visitors, safeguarding nurses, podiatrists, etc. But as we moved from being in the thick of the pandemic to more of a business as usual situation, we had to restart those services, and we simply don't have the staff to look after them. Hence us wanting to manage them within the main body of the hospital. We simply don't have the staff to be able to open up an additional area within Ward 20 in order to manage them, unfortunately, care for them.
But you did have the staff to operate Ward 20 separate from the main body of the hospital. And now we've got, two coming on 3 wards in the hospital, compromising the entire operational capacity of that hospital from the point of view of increasing the waiting lists, compounding the problems across the island. It's absolutely crazy.
It's not crazy, Mr. Mann. It's about having sufficient nurse staffing levels. We would love to have sufficient nurses to open additional wards to respond to COVID. As you've heard through the board reports, that is not possible. So when we open a COVID ward or a second COVID ward as we have now, that is converting an existing ward which would have taken other patients, non-COVID patients, surgical patients, and having to convert that into a COVID ward. It is based on staffing levels and ensuring our wards are adequately staffed, which is why we can't open additional capacity. The rate limiting factor is nurse staffing.
So you're at a critical level as far as your nursing care is concerned if you can't maintain more than 3 wards?
Well, what it means is that for every as we deal with more and more COVID patients, we have to convert other wards into COVID wards. Yes, we have a finite number of nurses, and that dictates the amount of beds we can actually open in the hospital and in the community.
So, following on into my next question, as far as whether you can cope with the TT, let's be truthful. You've got a critical state of the hospital at the moment. You've got the TT coming up in a few weeks' time, and you haven't got the capacity to operate things.
So to answer your question, to take your next question, would Manx Care please explain how it intends to provide a proper level of hospital operational capacity during the TT period, and if it has the ability to bring in extra staff and consultants during this period, why it has not done so routinely over the last year to reduce the waiting lists? Could Manx Care please confirm how Treasury has approached the matter, i.e. is Manx Care funded for the extra staff for TT, and not if it wishes to provide those extra staff during the remainder of the year? So the answer is that cancellation of elective orthopaedics during the TT fortnight has been commonplace for over a decade to ensure sufficient capacity for orthopaedic operations, as is the hiring of locum staff within orthopaedics and other specialties to ensure there is sufficient staffing for TT. Prior to Manx Care, DHSC did not recoup expenditure for the additional costs incurred during TT. However, this year Manx Care will look for recompense from Treasury. We cannot provide the additional staffing levels for the rest of the year, as that would be above our funded staffing levels. And then you've got another question about the TT. With the current COVID demand and lack of hospital resources, will Manx Care confirm that it has sufficient capacity to meet the demand of TT, and what contingency plan is in place if capacity cannot be met? Answer: Manx Care cannot predict the level of COVID demand that will be faced by the hospital during the TT fortnight. If it's clear that the hospital will struggle to cope with the additional pressure of TT, this will be fed through to the national around mitigation.
The people who have already arrived on the island by then, you'll have many thousands of visitors here, and at that point it's not just a case of the races not being able to run, it's a case that people are already here and the hospital won't be able to cope with them.
So this is the situation. So the situation is the same as every year. There is extra capacity brought in during the TT period. The uncertainty this year is as to the level of COVID at that time.
And a critical state in nursing care, because we haven't got sufficient nurses here to cope with the demand.
Yes, and I think that is a long-standing factor as well.
So why, Mr. Chairman, are we not being honest with the public at this stage and saying we actually can't cope?
Because I think we believe we can cope is the answer. We believe we can. You know, as the Chief Executive reported, you know, there are several states of operational pressure, and we reach level 3, but we don't reach level 4 at the moment. So that shows that there is still some room to cope with extra demand.
See, the difference between last year or previous years at meeting demand and this year meeting demand is that you already on the run-up to that event, to those thousands of people arriving here, you've already got a critical state within your hospital as to the occupancy of 2 coming on 3 wards, with what must easily be predicted to be an increasing rate of COVID. There's no sign it's actually dipped off sufficiently yet to go to
That is the risk, but I think what we're saying is that we believe that we can cope with that risk.
Well, I don't share your competence, Mr. Chairman, I'm sorry.
Well, you'll no doubt be able to come back to us if you're right or if you're wrong. We'll see when the time comes. And the final question is, will Manx Care please confirm whether the North West Air Ambulance Service has yet been used on the island for a patient transfer, and what the overall cost of the service is to the Manx taxpayer per patient or per operational year? How will it operate in adverse weather conditions, and what contingency is there if weather conditions are too bad for it to fly to the island? The answer is the Helicopter Emergency Medical Service has not transferred any patients to date. The costs associated with the service are commercially sensitive and therefore confidential. If the helicopter cannot operate due to weather or time of day, the existing fixed-wing air ambulance arrangements remain in place. If the aircraft can't fly, then use of alternative sea routes is made where appropriate.
Mr. Chairman, there's a figure of 350,000 in the accounts under the heading Air Ambulance. Is that fixed-wing ambulance, or is it the contribution to the Great North West Air Ambulance? I don't think that's commercially sensitive. is actually in your account?
It's a combination, but obviously what's commercially sensitive is what the cost per journey would be.
But that's only for a portion of this year, isn't it? Because the Great North West Air Ambulance has only just come on stream as part of this financial year. So what I'm looking for is the overall figure of the air ambulance service for a complete financial year, as costed out per patient per transfer. You'll have your previous figures for previous years of the average number of patients that are transferred by air ambulance. It's the cost per patient to transfer is what I'm looking for.
I think this is the air ambulance is a pilot and it will be evaluated. So part of that evaluation is that financial element. And I guess at this stage it's difficult to predict exactly how many patients will be flown off island using the HEMS rather than the fixed wing. So I would suggest we can probably provide a little bit more detail here, but it's probably best to wait for the full evaluation of the HEMS service, which will be undertaken by the transformation team.
Sorry, there was one further question, which actually only arrived yesterday, but we have actually been able to produce an answer. So the question was, given that a referral to the pain relief clinic denotes a patient in considerable long-term pain, and given that leaving an animal in pain for an excessive period of time would be regarded as causing unnecessary suffering, on what basis are current routine referrals to the pain clinic being delayed for months and patients being told that it may take as long as a year for access to an appointment? Would Manx Care please take immediate steps to introduce a programme of interim measures, additional clinics, stroke priority medication, to ensure that patients are not left in pain whilst awaiting excessive periods of time? Now, I think Oliver did actually cover that in his report on waiting list, and the answer is that pain management is one of the specialties that will be supported by the Medifa Virtual Outpatients Project. We've indicatively purchased 218 new outpatient appointments with pain management specialists working within Medifa, and there are currently 222 patients waiting to be booked their first appointment within pain management. We anticipate that the Medifa pain management clinics will start in June/July.
Mr. Chairman, my wife was only told yesterday that the waiting list for pain management is upwards of a year. So I'm sorry, and the Medifa is only doing a virtual telephone consultation. That's not going to cure somebody in pain. They need a prescription, or they need to be actually physically seen.
So Oliver, is that just a matter of...
Mr. Chairman, this isn't just something that can be left for weeks and months. It's gone on for long enough. If somebody's in pain, they're in pain, and they need treatment for that pain. They've been referred to the pain clinic to get relief.
Yeah,
How on earth can you say that you can leave it for months or a year? That's the patient's in pain.
I think the answer you've been given is that there has been extra capacity purchased to reduce the waiting time. And you know, that is the answer to your question.
So the answer is that we wait months?
No.
Somebody in pain has to sit waiting.
The answer is that the waiting times are being reduced by the purchase of extra capacity.
Mr. Chairman, I'm sorry, we wouldn't treat a dog that way. If you had a dog and you left it in pain and said, oh, well, we'll leave it for another few months, you'd find yourself in court. So
well,
how are we treating human beings?
It's like every aspect of healthcare. There has to be a degree of prioritisation for those who are most in need, but there is a pain clinic, there is extra capacity going into the pain clinic to reduce those waiting times, as per the figures that I've just read out to you.
Well, Mr. Chairman, I'll wait and see how soon that the appointment materialises and report back to you at the next meeting.
Thank you, I'm sure you will. Right, that's the end of the written questions. Does anybody else in the public have any questions? No. And do you have any further questions, Mr. Mann?
No, Mr. Chairman, thank you very much.
Right. Okay, so we have reached the end of this agenda. Thank you, everybody. We are a little bit early, but we'll bring it to a close there, and we look forward to seeing you all in 2 months' time, when there will be an extended event.
Yes, it's the board combined with annual general meeting, which will be an opportunity for some of our services to showcase what they have achieved during the course of the year. So, yeah, that's on the 24th of May.
Okay, so I declare the meeting closed. Thank you.
Thank you.